to that is a video. It's a 3-minute video. Michael Jr. is a comedian, also a personal growth developer, and Michael has like a close to a 4-minute video. The link is here for you. It's not a hyperlink, so you'll need to take it, put it in your URL. I encourage you to look at that video because this video really explains the importance of knowing your why, and you'll see just the profound, he does a profound job and an entertaining job of demonstrating how when you know your why, your what, and your how is more fulfilling. And after we watched the video, then we broke into dyads. People talked to the person next to them. So everybody got a chance to just focus on themselves before we start any learning, any thinking, any shifting, because with transformation, what we're really doing is shifting our mindsets, the way we think, the way we do what it is that we do. So I encourage you to take a look at that video, see what you think, and see if you can answer that question for yourself and share it with other people. The other thing that we explored, and you might also decide to do this, is that as we talk about being recovery-oriented, certainly strength-based is one of the principles. And some people have started to change their assessment tools when they're working with clients and asking their clients, what's your why, what's your purpose, and seeing that as a way to inspire, motivate people, and get people to think about the life that they want, not to focus on the problems and the issues that brought them to us, but really to start looking at the future. When we ask people in recovery, what does recovery mean to them? We get great definitions. People want to dream again. People want to contribute to their communities. People want to get their families back and to see their communities resilient. So asking different questions at assessments such as this one, what is your why, is also a tremendous way for you to work with the individuals that you serve. So, Diane, what I'd like to do at this point, Wes is with us, and I'd like to turn things over to Wes so that he can let everyone know what's going on in Florida. You all have done just some amazing things. I brag about you when I'm in other states. So while Philadelphia and Connecticut and Texas were some of the architects of rock and early adopters, Florida now is one of those that I just am excited and thrilled to always let people know how you're doing this, Wes. So can you take it from here and update everybody?
Good morning, everyone. Good morning, Lynetta. And I just want to say how much of a pleasure it's been to work with Lynetta over the past nearly 4 years now that she's been doing work with us here in the state. And I also want to say a big thank you to Fada for your incredible support, and Stephanie Humphrey from Fada, who joined us on the road over the past 2 weeks to help facilitate and organize these wonderful recovery management workshops. We really had a lot of fun doing this, and there was a lot of energy. And these workshops were really a way that we are moving into the next phase of our transformation of the state's behavioral health care system. So to provide you with some context for how we got here and where we're headed, what we'll do is we will move forward, not backwards. And so why do we need a recovery-oriented system of care in Florida? In 2016, when we initially began this rollout, we hosted a series of summits around the state, and some of you participating here today may have attended those. And that was part of the initial first phase of the state's process, was to disseminate the knowledge of what a recovery-oriented system of care framework is. And we did a lot of listening to folks who attended that summit, or those series of summits, because recovery-oriented system of care, those principles, those values, is about the community and listening to the community and giving the community a voice. And through all of those events that we hosted initially, we took a look at the information that we collected during those events. And what we saw were 5 priorities that popped out as common themes that are necessary in order to advance a recovery-oriented system of care framework throughout the state of Florida. And that first priority is collaborative service relationships. We know that it's important for us to all partner together and to work together. So really stressing the importance of how do we develop those collaborative service relationships to leverage those resources so that we can provide services in a manner which are reflective of recovery management principles of care, as well as cross-system partnerships, community integration. Community integration is critical. We know that folks don't live in the doctor's office, they don't live in the courts, they don't live in the community centers. Folks live in the communities as we all do, live in our community. And so it's really important that we help an individual to identify their own natural supports within their community so that they can sustain their recovery, because this is about shifting from what has traditionally been an acute care model to one that is focused on sustainable wellness. And then we also identified community health and wellness, because recovery-oriented system of care framework is about the community's health. As addition to that is peer-based recovery support services as one component of the recovery-oriented system of care framework. We know that peer-based services are a critical key component of a recovery-oriented system of care framework. So big picture here in connecting the dots, we had some really strong legislation that came down in Senate Bill 12 that actually, I went through and counted, talks about and mentions the word recovery 14 times throughout that bill. And that was remarkable for what we saw at the time, because we really had not seen that mentioned before. These are just 2 sections pulled out here. One is that in 2017, Senate Bill 12 required each managing entity to develop an enhancement plan for how they're going to enhance their services. And one of the principles and values is listening to the voice of individuals receiving services, as well as bringing in other stakeholders. So within that bill, we see the requirement to listen to the community through hearing from persons receiving services, their family members, local governments, law enforcement agencies. So what you see there is collaborative partnerships, stakeholders, all providing input to how we can enhance our service array. And we also saw that services should be provided, and just one example here is care coordination, should be provided with characteristics that are indicative of recovery-oriented principles of care. So this is just one of the examples of the supports that we have through legislation that we are seeing throughout the state that is really moving us more towards a recovery-oriented system of care. So we have all of this work that has been going on throughout the state over the years that has gotten us to this great priority of effort where we are today, which is to provide access to a recovery-oriented system of care for adults and children. And the goal of that is to enhance that system of care, being reflective of recovery management principles of care, shifting from what is traditionally an acute care model to one that is recovery-based model of care, because we can't just continue to think about treatment alone. We need to begin to be able to offer services and supports to individuals that are going to help them sustain wellness and recovery over the course of their life. And that means nesting services and supports within a community and helping individuals to integrate into their community so that they can connect to those services and supports beyond just treatment. So we have some large key activities as a part of the priority of effort, which are to implement enhanced standards, adapt oversight mechanisms, and incorporate enhanced standards in system planning, and develop those enhanced standards for managing entities out there across the state. As we know, it's important to be able to measure how successful we are at helping individuals to recover and sustain their wellness over the long term, and then make sure that we have mechanisms in place to monitor that as an ongoing process. So we have these milestones, and one is to implement effective outreach, engagement, and retention strategies. We know that effective, assertive outreach is one avenue to increase engagement and retention for folks when they're seeking services. We want to be sure that we're monitoring and improving care coordination activities through the continuum of care, and develop a roadmap for a community-based service array that comprehensively addresses the needs of those individuals that we serve, because we want to make sure that we're meeting folks where they're at and that we are providing the services tailored to the individual's needs. And we also want to promote that community and stakeholder integration and develop a recovery-oriented workforce as an ongoing process component of sustainability over the long term. So how is this done? As you move throughout your day and as you sit here and listen to all of the great information that's going to be coming to you here on this webinar today, think about yourselves and your roles and what you do every day. So everything is viewed through the lens of and aligned with these recovery-oriented values and principles of care. And so you're applying those values to what you do in your day and asking yourselves the question, is this recovery-oriented? Is the new program we're thinking about implementing recovery-oriented? Are these new policies and procedures we're thinking about developing, are they recovery-oriented? So as you listen today, think about those values and how they could apply to your role. So we have, as system transformation, some priority areas of focus that we know are important. We know that listening to the voice of the individuals and the families receiving services is critical, as well as offering choice for individuals. We know that it's important to have a menu of options for services, and it should be family-driven and youth-guided care. We know that cultural and linguistic competence is important, being able to meet folks where they're at and meet their cultural and linguistic needs, as well as being trauma-informed and making sure that we're providing an adequate and accessible array of services and supports to meet those folks with the services that they need. Because we want to see those meaningful outcomes for the individuals that we are serving. So we have in our statewide action plan recovery-oriented quality improvement specialists, and Lynetta talked a little bit earlier about those folks across the state. And the recovery-oriented quality improvement specialists are really unique to the state of Florida. These are folks within the department's regional office that are specifically tasked with coordinating local and regional ROSC efforts. And they're also tasked with going into provider organizations and identifying evidence of recovery-oriented principles of care. So this is a really exciting role that the state of Florida has developed to assist in this transformation process, as well as recurring technical assistance calls with the managing entities and the regional department change agents, because each managing entity has its own lead ROSC change agent. And that is something that myself and Lynetta have been working with these folks over the past year formally to help them to learn how to teach and transfer these skills of recovery-oriented system of care framework. So we have providing more opportunities for individuals and families to give back, to give feedback into the system. We know it's important to listen to the community because recovery-oriented values includes the voice of the community. So we want to make sure that we're promoting utilization of the feedback that we're getting and that information is getting to where it needs to go to inform those enhancement plans for service improvement and service delivery. So we have our local ROSC transformation efforts. You have the handout, you have your regional contacts, and each of those contacts, there's one at the departments and the regional department offices, as well as the managing entities, and those folks work closely together with their local communities to formalize and to listen to the voice of the community, to establish recovery-oriented system of care focused councils or groups that can really identify those community needs and then work to strategically plan how to make that shift happen within their respective communities.
So Wes, I think I've got control. I do. I'm now the presenter. Thank you, Wes. I learn something new every time I listen to you talk about what's going on in Florida. And in particular, I do want to just talk a little bit. Let's see if I can get back to, I guess I want to talk a little bit about those regional our ROSC leads, our recovery-oriented QI specialists. You all heard me say that in Simon's book, he talks about inspirational leaders. I have to say that the last year or so working with each and every one of them, they represent inspirational leadership. They're able to create partnerships with the stakeholders in their region. One of the things that is a component of a ROSC is peers. So peers aren't, it doesn't mean you're recovery-oriented because you add peers. However, peer specialists are a key component in a recovery-oriented system. And the thing that I was most impressed with in the state of Florida is that when they had these leadership positions across the state, as we were working to develop change agents and to build the capacity in the state of Florida so that you could continue this work for years moving forward, it's this group of people that has just been so inspirational. And I should have mentioned, when we started each day for those regional events, the regional lead, one or two of them in every region, opened up the day. They did the welcome and they set the intentions for the day. So they were, in many respects, co-facilitating the day with me, and they took responsibility and ownership for their region. So I can't say enough about them. As Wes mentioned, you've got the handout that gives you their contact information. And then when I share with you what happened in their individual gallery walks, it'll give you a little bit of an idea of some of the key takeaways that happen. So for the next maybe 20 minutes or so, I'm going to go over ROSC in particular, and then we're going to take a 5-minute break. The other thing I wanted to mention, please use the chat. If you have any questions, if a question comes to you in the moment, please use the chat. If it catches my attention as we go through this, I will try to answer the question. So please use the chat, and we're going to take a 5-minute break at the top of the hour. So as you see here, what is ROSC? What is a recovery-oriented system of care? And, you know, it's best understood when I talk about what it's not. It's not a program. It's not a model. It's not a new initiative. And as I mentioned, it's not adding peers to your services. And when I say providers, the other thing I want to make sure that we're clear around language. When I say providers, I'm talking about organizations who provide addiction and or mental health services. I'm talking about the courtroom, the criminal justice system, the hospitals. I'm excited that your state hospitals have joined this effort. So anyone who's working with individuals and families who are impacted by these conditions is what we mean when we say providers. So a group of providers that increase their collaboration doesn't mean that it's ROSC. If you look at the left-hand side of the screen, what ROSC is really a framework. It's a framework to guide whether you're an organization, whether you're a faith-based organization, the justice system, the hospitals, behavioral health providers. It's a framework that has values, principles, and goals. And so when, no matter which door, we sometimes talk about whatever door a person enters. If they come through the ER, the emergency room, for example, when you have a recovery-oriented community, if the hospital is a part of the ROSC, when they come through that door, the hospital has a shared vision around what is recovery and what do we do. So keep that in mind. It's a value-driven approach to structuring our systems and services. And so when you see this definition here, it's networks of formal and informal systems. So people in recovery, informal systems such as peers or recovery community organizations, which I'm so excited that you all are beginning to increase the number of recovery community organizations, the faith community. Formal systems are treatment providers and the professionals in those systems, the therapists, the counselors, the doctors, the medical director, the clinicians, certified counselors, and non-clinical services. So peers are non-clinical. However, both clinical and non-clinical workforce members are professionals. So we bring together formal and informal systems that are really looking to mobilize and sustain long-term recovery, not just treatment. Treatment certainly is a part of recovery for those who go through treatment, but treatment is not recovery. Recovery happens in the community. So as you see here, the system in a ROSC is not an agency. So if you're a provider on the phone, we hear many providers say we have a ROSC committee or we're becoming a ROSC. A ROSC is really a macro-level organization of a community, a state, in Florida's case, or a nation. We did this work in Africa, and as they look to transform the country there in East Africa, it was amazing to watch how these values, principles, and goals can be used in any and every community if we're wanting to help people achieve a quality of life in their community. So here are 5 of the primary goals for ROSC, and prevention is a part of a ROSC, as you see on the far left-hand side. So we start with prevention of the development of these conditions all the way over to that 5th goal, which is really promoting a good quality of life, community health, the community becoming healthy and having a shared vision around recovery is what it takes if an individual is going to recover in their community. We had one client when we were doing listening sessions around the country. He said, okay, I'm leaving this residential program, but unless you know of a relocation program that I don't know about, I got to go back to the community, and the crack house is right across the street. So I need some help with helping my community to get better. So ROSC is not only about the individuals in our treatment programs and in our services, it's about the health of the family and the community. So those are the primary goals, and there are 7 building blocks of ROSC. Today and when we had the summits, we focused in on building block number 1, aligning treatment with the ROSC. We also focused a little on number 2, and the peer support coalition was with us at every one of these events, talking about their efforts to develop networks, and we'll tell you about them in a moment. So we focused on number 1, 2, and number 5 because it takes a shared vision and collaboration within a targeted community. The other thing that I'll say about ROSC is that because it's principles and values, and as you look at these 7 building blocks, as you know, everybody's community is different. So even though the Northwest region is a large region that covers 14 counties, every one of those counties might approach this differently, as long as they all understand the values, principles, the 7 building blocks of a ROSC, and the goals of a ROSC. Each community will do what they do differently, some based on the resources in the community, the partners in the community, the culture of the community. You know, our rural communities look different than our metropolitan community. So every community looks different, and that's what I most like about ROSC, is that it helps us to get over ourselves, is how I put it. You know, the taxonomies and the silos that we've been talking about for decades, and it focuses us on the individual and the families that we're working with. One of the people here from FAR, and I'm not sure what FAR stands for, tells us that, you know, the residences in their community, they're helping people when they leave treatment with peer support and quality living houses. We've talked a lot, FAR, about housing when we were at those regional summits, so it's great to hear that housing is a part of the programming that you do. Now, why did this movement, and it is a movement, why did this start? It was about 20 years ago. I think it was President Bush, maybe the son, who created the New Freedom Commission. And when they looked at our healthcare system, our behavioral healthcare system, they said we needed a fundamental redesign, that the adults in behavioral health, you know, said that half of them reported that their challenges started when they were in childhood or adolescence, but we weren't seeing them until they were adults. And on the mental health side, the National Comorbidity Study said that people who needed mental health and SUD challenges, it was a decade before they would seek us out, and that we were only getting to less than 10% of the people who needed treatment. So we really needed to look at what it was that we were doing. And if you don't remember anything else today, this is one of the things that I'd like you really to take in. And the Institute for Healthcare Improvement and the World Health Organization has been working with all of us around recovery, and they created this, and the data just bears out that the factors that influence health status, and let's not be confused, recovery is about health. And the factors that influence health status is lifestyle, 51%. You see that big piece of the pie. Smoking, stress, nutrition, social support, peers, and 19% of the environment, our community, where we live, not only housing, but is the housing safe, and employment. So when you take those two, 70% of the factors that influence health status are in lifestyle and environment. That 20% is our DNA. We can't do anything about that. And 10%, that's treatment. That's primary care. So when you go to the doctor, 10% of what happens in treatment influences health status, but 70% of what influences health outcomes is in environment and lifestyle. And that's what ROSC is all about. It is not just about treatment. And the other thing that I was really excited about, and I put a couple of articles you have in your handouts written by Dr. Larry Davidson at Yale, one of the pioneers around mental health and addiction when we look at recovery. And in his article, he talked about the interface between both systems in this recovery movement. And in that third bullet, essentially he says when we focus on the nature of the illness, when I'm focusing on addiction and a mental health provider is focusing on that illness, it continues the historical differences that we have always had when we focus on the illness. But in the fifth bullet, when we both focus, when both systems, when everyone understands that recovery is personal, it's individualized, and that there are multiple pathways, when we all have that as a shared vision, that's when we come together. And our question, this is the paradigm shift for this work. We've always asked, how can we get populations healthier? How can we get people into treatment? We're moving from that question, this is where the shift is, to not only how do we get people well, but how do we help them stay well and thrive in their communities? World Health Organization also recognized this, and they put out this statement that we are talking about the state of complete physical, mental, and social well-being, and it's not just merely the absence of a disease. So I want to just take a look at a moment here. So I see that drug courts in Florida require that clients are housed through a voucher program. That is wonderful. So I'm telling you, housing, people going through treatment, for decades we focused on treatment, but if people don't have safe housing, if people don't have employment, it is very difficult. I won't say impossible. Nothing's impossible, but it is difficult for people to sustain and their recovery and have a quality of life without housing, without employment. So this is just a quick snapshot of things and people and services inside of a ROSC. So you see social support. You see that our schools and research, employment opportunities, AANA, and you all are starting in Florida, MARA, which is Medication Assisted Recovery Anonymous. So another support group for those whose pathway is medications with treatment, child welfare, healthy relationships. This is just a snapshot. And when we were at one of our regional events, someone from the Veterans Administration, she came up to talk to me about the work that they're doing around peers. So I added them. So you see veterans has now been added. So this isn't everything. The recovery community and peers are certainly there, but this lets you know that we're not just talking about treatment. Treatment is there. Medication is there. This is the conceptual framework for a community creating a rock and who all is involved. You could add the gas station. You could add the hangouts where people hang out. You're looking at the entire community, business owners. We heard a great example in a county there in Florida, Dixie County. There was a business owner who needed a better workforce, needed employees, and said that the opiate epidemic was just wreaking havoc on his business, and he met with the providers there and the group there and asked what could he do. To make a long story short, he wrote $1 million check to this recovery community as they're working not only around treatment, but they're looking at employment and business. So there are many partners and people that you'll want to collaborate with in your community. We like to show some of the successes. So we did this for the regions, and some of you from the different regions, I believe Big Bend is Northwest, you see some of the great things that they've done in all three of the circuits in their region. LSF, they've been doing a lot with the peer network and establishing partnerships with providers and the peer network. So these next couple of slides, and you'll get these so you can go back over them. Central Florida Cares. So you see that they got engagement and buy-in from their contracted providers. That's increased. And then, Wes, I hope that you'll have a chance to talk about the SAP in a little bit because you all had this great assessment tool that DCF worked with Dr. Jim Winarski at USF, I think, to create these assessments to determine the readiness and how recovery-oriented is an organization and what needs to happen to transform. And you don't only listen to yourselves. Part of the SAP is also an RSA where you're listening to families and individuals who receive service. So these are just some examples. Here's on the MOVE project in South Florida. So it looks like someone did a video, a peer integration video, and workshops at Southeast Florida Behavioral Health Network. So the managing entities and BCF coming together in every region has just been phenomenal as we've worked for the last 3 years. The other thing that I'll tell you about ROSC is that, and we'll come to recovery management after the break. The other thing I want to tell you about ROSC is that it takes time. Transformation takes time. Florida didn't say we just want to change treatment. We can change things. This is the difference between change and transformation. We can change things. We can change our mind. We can change the way we're doing something for the moment. But when you're looking to transform a system, transformation is really sustained change. And transformation is change that is evolving and growing, and it's an up and back. And transformation takes time. When we talk about it, we talk about there's an additive change, approach to change. You could take that strategy and just add peers. That's an additive approach. There's a selective approach to change where you could do a pilot or a demonstration and say we're going to do this in one part of the organization, or we're going to do this in one part of the community as a demonstration. But what Florida decided that they wanted to do was to change the culture, change the way we think, go for transformation, which includes also administrative changes. Your Senate Bill 12 certainly has helped, and there are other bills that I understand from Wes that are there that he'll tell you about in the next steps. So we're looking at transformation here, and when you go back to the architects of this, in Connecticut, Commissioner Tom Kirk was an integrated system. It wasn't just addictions or just mental health. It was both. And then Arthur Evans in the city of Philadelphia, those were some of our pioneers with this work. And they would both say that 7 to 8 years is what it took for them to literally transform their system so that what they were looking at was a quality of life in the community. We're looking at recovery, no longer just looking at an episode of treatment, but we're talking about the process and the continuum of recovery. So I think I'm going to stop here, and I'm looking, and I don't see any questions, Diane, that are here that I haven't at least made reference to. Halfways, somebody says that halfways are considered ROSC, and I don't know if you mean halfway houses. They are a part of a ROSC. A transitional house, Oxford houses, a part of a ROSC. So as I say, one organization, one entity is not a ROSC. All of this and more is what constitutes this ROSC framework. And what's important to remember is that we're talking about the values and the principles of being recovery-oriented, and we're going to go over those when I talk about recovery management. We're talking about the goals, the values, and the principles in all of these pieces, and that would include drug courts, halfway houses, treatment programs, hospitals, etc. So, Diane, I'm going to take a deep breath, and would you like to take a 5-minute break now?
Yes, we would. We'll take it 5 minutes. We'll be back on in about 5 minutes.
Okay. All right. I'll mute my phone.
Hello, everyone. Welcome back to today's webinar. Lonetta, are you ready?
Can you hear me, Diane?
Yes, I can hear you. Are you ready?
Okay. I am, ma'am.
Okay. I'm turning it back over to you.
All right, thank you. So, everyone, welcome back from that very short break. I'm going to continue now and shift the discussion to recovery management. And really, recovery management is this philosophical framework. This is where the shift began. We started with addiction, and as we work with SAMHSA, Dr. Larry Davidson, Bill White, and others, we looked at this shift not only for addiction, but for all of behavioral health in response to the New Freedom Commission's recommendation that we redesign our systems of care and that we look at a quality of life enhancement for individuals with these disorders. In your handouts, and I saw a question earlier about accessing the handouts. So I hope that everyone is able to access the handouts. There are a couple of articles that I put in there. One is around how the two systems, mental health and addictions, find common ground when it comes to recovery and how the teams, the service teams, integrate. So I encourage you to read the two articles that are there in the handout, and essentially what they both talk about when they think about recovery, when we're working in recovery, when we've understood recovery, is that no matter addiction or mental illness, that people in recovery want these things that you see here. Hope, they want to manage or eliminate their symptoms, increase their capacity to participate in social roles and relationships and have purpose and meaning and worthwhile contributions to their communities. And this one, I think, is really important when we're working with individuals coming out of the justice system, because we talk about community reentry and reintegration programs, and oftentimes people are coming out of prison without maybe ID or insurance or housing. So it's so exciting to me to see the Department of Corrections, Wes has been talking with them and working with them over the past 2-3 years, that the Department of Corrections and even the state hospitals looking at how they become more recovery-oriented, how they even use peers that come into the prison, come into the hospital, and start working with people before they leave those institutions so that they can start to build the resources that they need so that they're able to make those contributions and become a member of the community. One of the stories that I heard from a young man who was in prison, and he was working with his parole officer, and the parole officer, of course, had their standard protocols of what this person needed to do when he was back at home. The person was able to talk his parole officer, and they hadn't even looked at ROTS for recovery, but this was a parole officer who clearly understood that for an individual to be successful, they needed to take ownership and responsibility for their lives. So the gentleman got the parole officer to agree to him being involved in his faith community. There was a social group that he wanted to work with, and there was one other thing. The parole officer rewrote this guy's parole orders. And, of course, he monitored those things just as he would anything else. And make a long story short, 2-3 years later, this gentleman has a job, is married, has a family, is a homeowner, and that parole officer, in partnership with him, really focused on what we're talking about here. How do people recover in their community, and how do we help people have a quality of life? And when we look at all of this work, it's important. And this is the first part of the process. This is what we're doing in the regions and the communities there in Florida, is first helping people to create a shared vision so that we all believe the same thing about recovery, that we are all embracing the fact that recovery is not linear, it's a process. Part of the process is that up and down, as in any of our lives, any process of change and trying to become the best version of ourselves. It's a process, and that it is person-centered, and that recovery happens in the person's natural environment. So when we talk about recovery management, when we talk about long-term recovery outcomes, much like what the Institute of Healthcare talked about, the factors that influence health, those 70%, we've got some key performance arenas that we link to long-term recovery outcomes. These are just 8. They're the most critical, and there are others. I'm going to highlight 4 of them, but as you see the 8 of them here, attraction, early engagement, you see the 8 long-term recovery outcomes. I won't read these to you. I'm going to talk about 4 of them. And as I go through them, and then when you get the PowerPoint and you go through all of them, AC stands for acute care, and we're talking about limitations there, and then recovery management, the direction that we're going in. So when we talk about access and early engagement, one of the reasons, as you heard me say earlier, that this movement started was because we weren't getting to the people who needed treatment. On the addiction side, only 10% of the people. In mental health, it was a decade, and we waited for people to come into our offices. We wait for people to come to us. In a recovery management process, we have assertive outreach and engagement. We go out to where the people are, and we have assertive waitlist management. People talked with me for the last 2 weeks about waitlists. How can we manage waitlists? How can people get immediate access to service? And so when you partner, certainly the clinicians may not be able to take the client in right in that moment, but does that mean that they can't get any service? Where can peers come in and do pre-treatment groups, case managers? So when you work collaboratively and the service team integrates, as I said a couple of slides back, this team expands, and it is no longer just the treatment provider, the therapist, counselor, doctor, but if the team expands, we're able to manage our wait list, and we rethink motivation. Is it our job to motivate people, or are we really thinking that people should be motivated when they come to us? When you think about the stages of change, there's pre-contemplation, contemplation, and yet in our acute care model, we've been thinking that people should be motivated and ready when they come to us. So these are some of the recovery management directions that we're going in when we talk about recovery, and we look at some of our policies around discharging people. On the addiction side, traditionally, historically, when people return to use, we discharge them from our treatment programs. And yet we say that these are diseases like other diseases. Well, any other disease, when you present with the symptom that brought you to the doctor, say for diabetes, if you start eating McDonald's or whatever it is that you're not supposed to do, when you go in, the doctor doesn't say, well, I have to discharge you and I can no longer see you. So one of the questions that was asked early on was if we really believe, on the addiction side, if we really believe addiction is a disease, what would we do differently? And this is one of the changes in our administrative discharge. And that's not to say that there aren't reasons that people are discharged from our program. Safety and violence, et cetera, are some of them. And as I mentioned earlier, the composition of the service team certainly expands, including primary care physicians, so all of the community, many of the people that we serve have other medical conditions, and we should be partnering with those professionals as well, because the individuals we serve, they want us to see them as a whole person, just like we see ourselves. Some of them have said, the disease is not me. I have a full life. I'm trying to create a full life. So we need to look at the whole person when we are working with the individuals using this recovery continuum. The other thing that shifts, when I came along and worked in the treatment system, we were the experts. In the acute care, we were the experts. We knew what was best. We had these template treatment plans that says you do this, 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 and you will successfully complete treatment. In a recovery management model, we're in partnership with the individual, and the client is the co-leader here, and they have choice, and it is person-centered. So that is one of the shifts when we talk about our relationship with the individuals that we work with. And when they have a goal, something that they want to work on, we don't judge that goal. We encourage the goal. Even if we thought the goal may not be attainable, who are we to say that someone cannot achieve what it is that they want with support? So our job is to support. One lady mentioned at one of the summits that her client wanted to work at Disney. And being in Florida, that makes a lot of sense. Now, this person had not completed high school, and there were some other things, and rather than the professional that was working with her say, well, you haven't finished high school, so you can't do that, she started in a process of looking forward. What's your purpose? What do you need to do? What's the first step we need to take? Should we finish a GED, whatever that is? And she got in partnership with that individual, focused on what that individual wanted for her life. So that really changes our relationship with the individuals that we work with. This is also one of the key questions. In our acute care model, we wanted to get the individual to come into our world. We were focused on how do we get them into treatment. You see the new question here, how do we nest recovery, that person's recovery, in their natural environment? Or how do we create an alternative recovery conducive environment? How do we work with them? One of my Native American partners, Don Coyhes, he talks about this from a healing forest metaphor, where he talks about a tree that is sick in the soil, and everything around the tree is sick, and the tree is sick. You dig the tree up, plant the tree, transplant it into healthy soil, and the tree is able to heal and grow and thrive. Once it's healed, you put them back in the unhealthy soil, and I'm sure you know what happens. So this is why we need to look at the community. People make progress in treatment, and they go back into their natural environment that may be unhealthy. And so this expands our work to really partner with the community. Don't see any questions here, so I'll keep going. So the implications. Here's another thing, another cliche, and a thing that we were taught was wait for people to hit bottom, and then they will come to us. And this outreach worker said to us, my clients don't hit bottom, they live on the bottom. If we wait for them to hit bottom, they will die. The obstacle to their engagement, everybody, it's not that they don't have pain. That's not really our focus. Our focus is that the hope is what's absent. They have no hope. So that suggests to us that when people come in, they are not ready. And it's our job to help them to build hope, then to activate that hope, and how we do that. So this early outreach and engagement, meeting people where they are, and how do we do that? These are some strategies that you see here for offering people hope. Rather than having them wait 2 weeks before they can see a clinician, pre-treatment support groups gives them hope. Going into the jails and prisons before a person comes out gives them hope. Building linkages, using technology, telehealth, particularly in our rural settings. A lot of people are using telehealth. And then this one, and this one is really important, is that we use at our front door the most charismatic, the kindest person at the front door. It's just like when someone comes into your home, if you open the door and you've got an attitude, who wants to come in? You know, so we've got to really look at who's at our front door, because if I come in for treatment, I'm already afraid. I'm already in contemplation, perhaps, and I bump up against someone at the reception desk who either has a major attitude or makes me feel like I don't belong here. I'm not welcome. That is one of the very first things you can do to become recovery-oriented, is make sure that your front door, the pictures that you have, signs that you have in the bathroom, that things are welcoming, that they're strength-based, and that they're positive, and connecting with people before their initial appointment. Certainly clinicians don't have time to do that, but when you expand your team, peers can connect with people. And if people are absent, peers can check and see what happened. So when you get a chance, come back and look at this sort of status check to see what your outreach and engagement looks like. And if you answer yes to any one of these questions, you want to rethink and change whatever's going on here that you say this is one of our challenges. You want to look at that. For example, if you have lengthy and repeated assessment processes, when Wes and I talked with the hospital, they talked about all the assessment forms that they have, and they're looking at that because they do have lengthy and repeated assessment processes, as many of the providers do. Or do people have to have multiple appointments before they actually begin treatment? Or do we discharge them when they miss 3 appointments? Or do we have outreach when they miss appointments? If you answer yes, so this is sort of a checkup for yourself. You know, kind of check and see where your organization stands. Are you recovery-oriented when it comes to outreach and engagement? These are some of the benefits, and I love to share these because for any directors and policymakers who may be on the phone, these are some of the outcomes and the data that was collected in Philly and Connecticut when they did assertive outreach. Certainly when people aren't there, we can't bill for them. So when we have no-shows and people aren't remaining engaged in treatment, we're losing money. In Connecticut, when they reduced the wait times and reduced the no-show rate, they increased admissions, so you can see they saved $172,000. And the Jewish Employment and Vocational Services in Philadelphia, that was a prison program, a justice program, and they increased retention. So they had a partnership with the provider, and they increased people's retention. and they made $250,000 by doing that. So you see the dollars here when we re-engage people. So people don't show up, but if we can re-engage them, because if people aren't there, we're simply losing money, and we do need the money so that we can continue to provide the services. Assessment is different. It is not just do an assessment, put it in the drawer, or do the assessment today and not do it again. People coming into our programs are feeling a certain way today. They're new in recovery and will feel differently next week, next month. So assessment in a recovery management model is an ongoing process, and the focus is on strengths and recovery capital. And recovery capital are the strengths and assets that an individual has that can help them sustain their recovery. It may be personal capital, friends, families. They may have a job. They may have housing. They may have a car. All of that's recovery capital. But you also want to look at what's the recovery capital in the community. If it's a mom who needs to go to IOP groups or needs to be in services, and there's a phenomenal daycare program in the community that maybe has a sliding fee scale, that would be community capital. Or employers who will hire individuals, say even individuals who have felonies. That's strong recovery capital in a community. So the state of Florida and West has introduced recovery capital, and you'll be hearing more about that. I think there are workshops around that. And when we have our assessments, changing our questions is a great way to become strength-based. Our questions have all been deficit-based, looking at the problem. But when you ask people questions like what you see here, what are some of the things in your life that you hope you can do and change in the future? What dreams did you have before you started having problems? We want people, just like all of us, to realize that it's their right and that they should be dreaming about what it is that they want. I love this last question. If you went to bed, that's my magic wand question, and a miracle happened while you were sleeping, what would be different when you woke up? And how would you know things are different? So some of the providers that we've trained over the last 3 years, while you do have questions that you have to have because of billing, policies, et cetera, it doesn't mean that these questions, as you're working with a person and trying to get them to create a quality of life, that these questions, such as that question we asked at the beginning of the day, what is your purpose? What do you think your purpose is? Those are strength-based questions that we should be asking at assessment and throughout the time that we work with them. So I talked about the guiding principles of a ROS, person-centered being one, being strength-based another, that we're in partnership, that we're culturally responsible. And that's just not from an ethnicity standpoint, but what's the culture in the community? What is the community ready to do? Some communities have said, we're not ready to talk about medications yet. And over time, as they understand that medications is one of the many pathways to recovery, this is just a snapshot of values and guiding principles in a recovery-oriented system, in a recovery-oriented provider organization, in a recovery-oriented courtroom, hospital that is strength-based. This partnership consultant, doctors have shared with me that they like that especially because they call it activated patients. They want the patients to get in this with them, that they're not God, you know, and the doctor wants us to be activated patients, or we call it partnership and consulting relationships. So these are what our traditional plans have looked like. They haven't been individualized. They haven't been strengths. We may list them, but we don't use them. And our traditional plans have not connected to the goals and what's important to the person. So those person-centered plans, like on the left, what is the person's perspective? They want purpose, and they value that, and faith and spirituality. I'm not talking about religion, but spirituality. We're all spiritual beings, and these are the things that's important to them, a home and place of their own, meaningful relationships. Now, for the professional, we're also focused on health and safety and meeting legal obligations and harm reduction and community safety. Both of these are important, and we want to balance both of these and come away from just using our professional perspective. Here's a study Dr. Tundora did in New York. When they used a person-centered approach, these were some of the benefits. You see 43% decrease in ER visits, 11% decrease in arrest, 44% decrease in inpatient days. This came from them taking a person-centered approach. Every single one of us is a unique individual. The things that are important to us are unique. And so in a recovery management model, those are some of the results. I don't see any questions over here, so I'm going to continue because we want to get to the gallery walk that we want to do with you. So I'll go quickly through these next few slides. So when we're talking about being community-based, I've talked about this over and over and over. This is the new question. How do we nest the process of recovery within the person's community, within their natural environment? That is the primary shift for treatment. These are 8 domains. It's not all of them, but 8 domains of community inclusion. If you go to SAMHSA, Substance Abuse and Mental Health Services Administration, where all the federal dollars are, you will find where they talk about recovery and wellness and more information on these domains. So part of my goal, and I told the people at the summit, part of my goal is to confuse you because I want you to dig deeper. I want you to go and read the resources and the handouts we provided. I want you to go to SAMHSA's website. I want you to really start becoming students and experts in what does it mean for us to help individuals, families, and communities to have a quality of life, and how do we do that? So these are 8 domains. Peers certainly are a component, and these are some of the things. We talked about hope. So if people are coming in looking for hope, having a peer meet them at the door. We've got some hospitals where there's a peer in the ER. There's a peer in the prison. Having a peer involved, certainly with their lived experience as their main credential, not their only credential, but whenever I'm with someone who has sort of experienced something similar to what I'm going through, I feel like I can talk to them. And they do give me hope when I see that they were able to come out on the other side. So these are some of the things, the outcomes when you integrate peers into your programs, your systems, your hospitals, your recovery homes. And Florida's plan to increase peer-based recovery support services really was around those ROKIs that Wes and I talked about, the Regional Recovery-Oriented Quality Improvement Specialist and Peer Support Coalition. You are one of 4 or 5 states that has a statewide peer support coalition. The other thing is that first bullet, I don't want to skip this SAP because what we discover when we ask people about our services and how we can do better, we learn how to align our practices by getting clarity through the utilization of that assessment tool. Let's see, what else do I want to tell you? Magellan, you all have a managed care organization. Magellan had great results, and they have an internal peer support program, And when you study this, you can go back and look at the results. If Dana Fogelsong was with us, she could do a much better job of talking about how they save money pre and post readmissions, decreased after using peers. So they have a strong peer support program in Magellan there in Florida, and I think Magellan in Pennsylvania. So you may want to Google Magellan and their peer programs because they've done some great studies and outcomes of the work that they've been doing using peers as a managed care organization. Peer Support Coalition, you have a great statewide program, as I say, one of maybe 4 or 5 states in the country. And one of the things that you should know is that they're peer-run, non-for-profit, and led by peers, and they do peer education, technical assistance, and what they're doing around the state, and Wes draws this out beautifully, is creating regional networks of peers. In the Northwest and Northeast, there's Denise Barber, Cheryl is Central and Sun Coast, Southeast and Southern is Kimberly Comer. They're building these regional networks. And if you go to Peer Coalition's website, I'm not sure if it's on their slide here. I don't see their website. Wes, I don't know if you're unmuted, if you could add anything to the network that Peer Coalition is creating around the state. Anything you want to add if you're here? Thanks, Wes.
Sure. Thanks, Lynetta. So the Peer Support Coalition of Florida is doing really great work around the state by building these peer networks throughout. They're currently looking at peer councils or peer networks that are already established out across the state, and also looking to identify other areas in the state that folks may be looking to establish a local peer network. So the work they're doing through their grant, their statewide peer network grant through SAMHSA, Denise in the northern part of the state, Kimberly Comer in the southern part of the state, and then Cheryl in the Central and Sun Coast region part of the state are working very closely with those local peer councils and local networks to connect them to a much larger network across the state, because this has so many benefits when you establish a statewide network, because information then flows back and forth across the state, across these networks. Resources are shared, training and other opportunities are shared. But outside of that, one of the benefits of peer workers being connected to a much larger statewide network is that sense of support that they receive by just being connected to other peer workers throughout the state. So this is a really exciting time because this is really not something that we've had established before in this way in Florida.
Right.
So their website is peersupportfl.org. If you are interested in visiting their website, and they have a lot of resources there on their website. They have something that is available to providers to post job openings at provider organizations for peer services, and also peers themselves can go and upload confidentially their resumes to the coalition's database. So they're really working to pull this network together, and also doing a lot of work for us at the state by coordinating these recovery-oriented quality assurance site visits. So we're really excited to have the Peer Coalition as a strong partner in this effort.
Wes, I wonder if you could, in the chat box, if you're able to, I know you're probably getting ready to go to your next meeting, if you could type in that website for Peer Coalition in the chat box.
Sure will.
Thank you. Thank you.
You're welcome.
So before we talk about the gallery walk, just back to the Peer Coalition, if you want to get involved, use that handout where you've got the regional ROS leads, because they're in close partnership with Peer Coalition, so you can get to them. And I believe Cheryl actually is on that contact list. Peer Coalition, I believe, is on that contact list. Are they not, Wes? I think they're on that contact list. So you've got Cheryl's email information, and you certainly have your regional lead. So now what I want to share with you, this gallery walk that you've heard me mention, I'm going to just quickly, and I think Diana's going to pull up, I wanted to give you a snapshot of what happened. You see this picture here. So essentially the gallery walk is a small group activity where people are up and brainstorming together. And the picture that they're looking at is essentially a question. And each group gets to answer every question. So we go through, we sort of do a round robin, so to speak. What we want to do, we give them 2 minutes. What we want to do is give you 1 minute. And I think what Diane has typed here, and then we'll share with you what we found out in the regions. So right now, you get 1 minute. We give them 2 minutes. And this is the thing about the gallery walk. This is just one of the activities during the day where we get to hear from, and you get to have a voice and get involved and participate and influence what's going to happen as your region begins to put together its strategy. So you all get 1 minute to answer the poll question. Cheryl, did the poll end? Diane, did the poll end? Where are we with this?
Hi, Lynetta. I started that poll quicker than my call. I'm going to reset that poll, everyone, and I'm going to start that poll over.
Okay.
I did it really quick.
That's okay.
So
she's going to put the question. Okay. I'm sorry. Go ahead. What are you saying, Diane?
So I'm going to go ahead and post that question again, and in the next 10 seconds, and everyone, the poll will open up, and you have 1 minute to complete it.
Great. So answer the question, everybody, that she's posing to you all right now. You can answer it in the chat box, and let's see what you think and get your voice included. So this is our virtual gallery walk. So I'm hoping that people are answering the question. Looks like you've got maybe 30 seconds left. And this is how the gallery walk works. I let people know. We start counting down. Got about 5 seconds, and it's going to close. Great. So I believe Diane is able maybe to show me what some of your answers were in the gallery walk. And you're going to get an opportunity to answer a second question. So it looks like the results are coming up. I don't know that you all can see them, but I think I'll be able to see them. Wes, I think you'll be able to see them, but I'm not sure.
So, Lonetta, you and Wes should be able to see the answers. The participants, you are not able to see them.
Okay.
Would you like me to go ahead and post the second question?
Yeah, would you post the second one? I don't see the answers, Diane, but please. So the second one has been posted, everyone, so please answer the second question. You've got 30 seconds, everyone. Has the polling ended, Diane?
Yes, so I closed the poll for the second one. I had 42, 43, 44. They're pulling up.
Wow. Okay. So for some reason, we're not able to see the results.
So, poll results.
And while,
okay.
Yeah,
I'm going to do some looking here for you and see if I can't get them posted.
Okay, all right. And while you do that, I wonder, let's see, what time? We've got 15 minutes left. Can you pull up the document that has the regional gallery walk? And after that, Wes, we're going to go to next steps.
Okay, that one or the...
So as I mentioned, everybody, at every summit, and all of them had different questions, and it was the Ross lead people that we worked with, because there are two things about the gallery walk. Number one, it gives you an opportunity to get information from people that you want to become involved and take ownership and be a part of what you're doing. So some people use the gallery walk in staff meetings. Some people use the gallery walk when they're having community meetings or they're meeting with clients. And the quality of the question will determine the quality of your answer. So whatever your question is that you're wanting to know about, maybe you want to change some things within your team, ask good questions. You know, if you want to know what they think works, let that be a question, or any ideas that they might have, or any obstacles that they perceive, or how do we make things better here. The quality of your question, and this is just an excellent way people get engaged, even the people in the room who are the introverts, who may not talk during the large group discussion. I'm always thrilled when I see that those very people that weren't talking in the big room are the ones that have the magic marker. They're either writing or they're talking. So it's just another way to engage people and to have different ways to find out information from individuals. So if I still have control here, I do. Wes, if you're there, I'm going to move us to next steps. And if you could take maybe 5-7 minutes on these next 3 slides to let people know what's coming up next in the state.
Okay, sure. Thanks, Lonetta. So we have a lot of supports that are supporting this transformation. Those of you that are familiar with the system of care grants, those system of care grants, those principles of care that approach all those values within a system of care align with recovery-oriented principles of care. Care coordination is a large component of a recovery-oriented framework. We have the department's priority of effort. We have statewide and regional and local ROS efforts occurring at this time around the state. So we have a lot of moving pieces that are all a part of this transformation. And at the state, at the regional and local levels, different communities are at different stages, and that's fine because it is responsive to the community's needs. So moving forward, we've been fortunate to have FADA support us in offering a host of webinars that align with these recovery-oriented principles of care, removing stigma. I'm not going to go through all of these, but you can see them here. And for those webinars that have already been facilitated, you can access them on FADA's website in their resource center. You can locate the archive webinar there. Been some really fantastic webinars. We have the 6 regional recovery management workshops that Lynetta and myself just spent the last couple of weeks moving around the state facilitating those. The agency quality supports for peer recovery services workshops, those occurred around the state and were very helpful to helping provider organizations understand the process for integrating a peer recovery service. It's much more involved than just adding the service to a provider service array. There are several items to consider, such as policies and procedures, as well as supervision and clear role delineation for the peer worker themselves. And then we have quality assurance monitoring activities that are not really monitoring, we're calling them transformation assistance. I'm actually here in Miami right now participating in one of those quality assurance recovery site visits in which we are going in to provider organizations and supporting them in identifying evidence for recovery orientation and then supporting them through the development of a strategic plan for how to increase recovery-oriented principles of care within their treatment or within their service practices.
Great. The other thing, and I really am promoting and pushing you, I hope, encouraging you to contact your local ROS lead. Use that handout because they have these handouts and tools that they can share with you, and all of them have various ways for you to get involved with them. They either have formal community ROS committees, they have regular calls, they're creating new committees, new networks being created with the Peer Support Coalition. All of those things are available to you, and those ROS leads, they're there so that you can get whatever you need following today, whether it's tools that are here. Certainly the Recovery Capital Scale is one of the handouts that they can share with you. Wes, we've got about 8 minutes. Can you, in a couple of minutes, should we say something about the SAP here?
Yes. Thank you, Lynetta. So the SAP tool is a really important tool for us in this process. And if you're not familiar with that acronym, because we have so many that we live with, it is the Provider Self-Assessment Planning Tool. And this tool was developed at the University of South Florida's Florida Mental Health Institute. And one of the key developers was Jim Winarski, who we have partnered with as a part of this process. And the SAP tool is really helpful for provider organizations in identifying evidence of recovery-oriented principles of care, those values. The SAP tool itself has 3 domains: administrative, community integration, and treatment services. And then there are about 50 items divided up amongst those 3 domains. And a provider organization utilizes this tool to assess those 3 domains and identifying evidence of recovery orientation. And a component of the SAP tool is the RSA, which is the Recovery Self-Assessment. And this is a really critical component of this process because the RSA listens to the voice of the individuals that are receiving services. And so the individuals that are receiving services are also answering some questions about the provider organization from which they are receiving services. And then once those responses from the SAP and the RSA are collected, it's meant to be a part of a routine CQI process. So those responses are then put up against each other, and you're looking for disparities in those responses. And one of the things that I've seen come out of provider organizations completing this process or doing the SAP and the RSA is the value in the conversations that are then begun as a result of those responses. And the SAP tool is really helpful because it guides and provides resources and recommendations for how a provider organization can improve in their own recovery-oriented context in those 3 domains.
Thanks, Wes. So let's see. I'm going to keep pushing this. How can you and how will you get more involved? Contact your local ROS lead and get involved in this movement. I'm just so excited that so many of you joined us. And as I say, I wanted to confuse you enough so that you would keep digging deeper. At the end of your PowerPoint, there are the references here and articles that you can access to get information. There are monographs and books and websites. I strongly encourage you to go to acharaconsulting.com. Dr. Ijama Achara really helped Wes and I as we started. She is one of the national subject matter experts on all things ROS, and if you're interested in looking at peers, there's a peer toolkit that she also helped to create. And then WilliamWhitePapers.org is another invaluable site. You'll find many resources there. So get involved, contact your local ROS lead, and I'm hoping, Diane, that the results of the virtual gallery walk, this is the first time we did one, if you could get those results to Wes and I so we can see how people responded to those 2 questions, because it is the state of Florida, you all on this call, that are helping us to shift the way we think, shift the way we do things, and shift the way we treat people. You know, both Wes and I love Maya Angelou's quote where she says, people will forget what we said, and they likely will forget what you did, but they will not forget. They will always remember how you made them feel. So this is about how do we treat the people, the families, and the communities that we're serving in a strength-based, person-centered way that is focused on supporting them in creating the life that they desire. I guess my closing quote, Diane, and then I'll turn it over to you, is really in this statement that many of you on this webinar are already linked to leadership in this movement. It's an emerging movement. And some of you, you know, you were born for this. You know, your whole lives have prepared you for this moment. Wes and I, DCF, FADA, the managing entities, and certainly those regional ROS leads. They are phenomenal. We invite you to join us. You've got all of our information, and I don't see any other questions, Diane, so we're 2 minutes at the top of the hour, so I will give it back to you.
Thank you, Lonetta and Wes, for your time, your expertise today. It was great information, and I know it served our attendees very well. So when I conclude today's webinar, your browser will take you to an evaluation on FADA's new website. If you want to receive CE credits or a statement of credit for this event, please complete the evaluation. Let me turn over to you will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. After you register or sign in, you will be directed onward to the evaluation. You may consider using the same email address when you register for webinars through our WebEx link and when you set up your profile in FADA's system. This helps connect your attendance and your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today. In about 30 minutes, the sender will be Messenger at WebEx. Evaluation will close at midnight on Thursday, February 28th. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. Thank you for participating in today's webinar. We'd also like to recognize and thank especially the Florida Department of Children and Families, Office of Substance Abuse and Mental Health for funding today's education. Have a great rest of your day, and please hold for the evaluation.